Appearance of the normal bladder. The normal bladder neck. As soon as the bladder begins to fill with fluid, one may examine the bladder neck. With the prism directed upward, the cystoscope is gently withdrawn until there suddenly appears in the field, close to the instrument, a dark red body. This is the bladder neck. If normal, it has a crescentic fold with the concavity away from the cystoscope. This fold may be smooth and regular, and upon it one may see the red outlines of the vessels within the mucosa, or it may be lumpy and edematous looking, showing no visible vessels. Though such a picture suggests inflammation, it may well be entirely within the normal, and one should not infer that the bladder neck is inflamed unless the cystoscope shows evidence of inflammation elsewhere. Keeping this crescentic fold in the field, the cystoscope is now revolved in the direction of the hands of a watch. The normal bladder neck retains its concave, sharply outlined appearance until the cystoscope has made about 1/3 of a revolution. At 4 o'clock, however, the sharply outlined ring flows insensibly into the trigone. The ring is lost in this red surface until the cystoscope has completed another 1/3 of its circle. Then, at 8 o'clock, it is picked up again and carried around to the starting point. At the junction of bladder neck and trigone, one can follow the lateral edge of the trigone as a rather well-defined ridge by pushing the instrument inward. The normal trigone. Having completed the inspection of the bladder neck, the cystoscope is once again revolved a half turn to 6 o'clock. With the prism looking downward, it is now pushed into the bladder about 1 centimeter, and as it goes, one observes the surface of the trigone, a surface covered with a sheaf of vessels spread fanwise from the bladder neck toward the posterior edge of the trigone, interureteric bar. That these vessels are not plainly visible may simply mean that the prism is too close to the trigone. Depress the instrument a trifle, and they spring into view. After the cystoscope has thus been pushed in about 1 centimeter from the bladder neck, the edge of the trigone, the interureteric bar, springs into view. Up to this point, the mucosa of the trigone has been smooth, a rather dark red, and streaked with its radiating vessels. Beyond this transverse bar is seen the fundus, rather wrinkled than smooth, distinctly paler than the trigone, and etched with smaller vessels running hither and thither quite irregularly. The prominence of the interureteric bar varies greatly in different individuals and with different degrees of bladder distension. If the bladder is only partly filled and the patient a man, the bar usually stands out quite distinctly with a definite pocket immediately behind. But if the bladder is distended and the patient a woman, especially a multiparous woman, the trigonal markings may be quite obliterated, so that one cannot tell precisely where the trigone ends and the fundus begins. Here again, the novice is likely to make the mistake of keeping the cystoscopic prism too close to the bladder wall. If he becomes confused, let his first thought be to depress the ocular end of the prism in order to get a more distinct view of the interureteric fold. Indeed, if the lens is kept a little way from the trigone, the whole of it will be inspected by the motion of pushing the cystoscope in until the interureteric fold comes into view, and then turning it to find the ureters. The normal ureter mouth. After the interureteric bar has been identified, the ureter mouth is brought into view by simply rotating the instrument to right or left until the angle of the trigone is seen. Figure 26. As the cystoscope turns, the eye follows the bar until a marked angle, or rather peninsula, of smooth trigonal surface is seen. This is marked by a few remaining radiating trigonal vessels, is more or less elevated from the surrounding fundus, and extends laterally and upward to be lost in the bladder wall. Figure 26. Maneuvers in catheterizing right ureter. Prismatic cystoscope. 1. Cystoscope turned to 6 o'clock to fine interureteral ridge. 2. Cystoscope rotated following ridge. 3. Beak of cystoscope moved toward ureter. As soon as the angle of the trigone is brought into view by rotation of the cystoscope, the rotary motion is exchanged for an angular depression, whereby the ocular end of the instrument is turned away from and the prism is brought toward the angle of the trigone. Near the base of the little peninsula, and usually fairly in its middle line, the ureter orifice will be seen. The description of the ureter orifice is an entirely hopeless task, for no two normal orifices look exactly alike. The color depends largely upon the illumination and distension of the bladder. One may lay down the rule that neither ureter orifice nor bladder neck should be considered inflamed unless there is evidence of inflammation on the adjacent bladder wall. In shape, the normal ureter orifice may appear a wee round hole, a slit, or a U-fold of mucosa. Contraction of the ureter shows itself by a slight motion in the mucosa, followed by a sudden opening of the little hole or slit from which comes a swirl of urine. No very profound conclusions can be drawn from watching the contractions of the ureter. It may be important to note that a bloody or purulent flood issues from it, and one may note that it does contract. But that it does not contract proves nothing. This may be due to reflex inhibition of peristalsis. Another way of finding the ureter. Inasmuch as the ureter mouth lies at the junction of the base and lateral edge of the trigone, it may be found by following either of these lines. The method just described is the most generally satisfactory, but in some instances, obliteration of the trigonal markings may make the lateral edge of the trigone a better guide. This extends from the bladder neck at about 4 or 8 o'clock, almost directly inward to the angle of the trigone, and usually can be quite readily followed if the prism of the cystoscope is depressed fairly close to the trigone and rotated toward the side so as to throw the lateral edge into sharp relief against the bladder wall behind it.